Can you see me circling around the heparin? Oh, thank you. No. Okay. How about like now? No? No? No. Okay. All right. The hand is not working, my pointer. I thought maybe today it would. Oh, how about this? Can you see me pointing with this? Oh, okay. All right.
Yes,
We can
yes.
try that. Okay, great. We'll try that today. Wonderful. I like pointers. We'll wait another minute. We're getting up there, but we only have about 3/4 of the class right now. So I don't want you guys to miss stuff so that you're confused. Because the medications, we're going to start with the medications, and the medications can be a little bit confusing. I don't know if Taka Oppenheimer, if you're here right now, and Sandra Patterson, if you are here, please check your email. Sandra, yes, I do see you here, and I don't see Taka Oppenheimer. Okay, if you could check your email. There's a message about those of you who have OB evening clinical this week, only evening clinical. So please check your email. Okay, that'd be very helpful. All right. So we're going to get started because we're going to start with something that I always start with. Now, why do we need to exercise and move our limbs around, our arms around, our legs around? Why do we need to do that? And why do we need to instruct our patients to do that? Because we want to prevent a DVT. Excellent. Right. Great. Prevent DVTs by moving around. Yes. Because remember the Virchow's triad we talked about? So one of the pieces is what? As to why we need to move around so that we can prevent it. What causes a DVT? There's 3 things. Stasis, venous stasis, exactly. So those are for people who are on long plane rides, all that. So we're going to start with that. But today I'm going to have you guys, I think some of you are sitting, maybe some of you are sitting in bed and laying down, sitting with your feet up. But I think most of us are hopefully sitting in a chair like I am. And I want us to even just move our legs straight out and straight up, extend our legs. Okay. Right now they're flexed if our feet are on the floor. Let's just extend our legs one at a time. First the right, then the left, now the right, then the left. Okay. This is something we can do with our patients. Okay. Just have them extend. Now extend your leg, hold it up for a minute. Now flex and dorsiflex the foot. Okay. Feel that? We're extending the calf muscle. All right. Everybody do that. Now we're going to do it with the opposite leg. Bring it up. Extend it. Flex it. Extend it. Flex it. Okay. Bring it down. And now what we can also do is just stand up a minute. Okay. We can march in place. I always love to stand up. Okay. We can stand up. And then we can also bring our knees up. Bring our knees up to our chest. Okay, let's do a little bit of that. Get the blood flowing because we don't want the blood to be stagnant. Because if the blood is stagnant, it's going to want to just naturally clot. The platelets are going to want to get together. They're going to cling together. We don't want those platelets clinging together. Okay. All right. That's good. Okay, the other thing we can do is bring our arms up. We can sit back down, bring our arms up over our head on both sides, go back and forth. Just simple little things. These are things we can do with our patients when they're sitting in bed. Just have them bring their arms up over their head. Have them extend their arms out. Have them extend their arms up. Okay, just up and down. We could just have them do it up and down just to get that blood moving around. Okay, good. It's 9:30, so we're going to get started. I have a lot of material to get through that I'd like to get through. It's fine. You guys can review it on your own and we can go over just some case studies and things. But I like to, as you know, my style, I like to kind of give you the information that I feel is very pertinent. I'm going to tell you what you need to know, what is not as important, but good to know. But also important stuff for, I know you're all worried about the exam and what is going to be on the exam. These medications are going to be on the exam. I'm going to ask you if you could jot down your questions and please hold them because I'd like to get through the material and then I'm more than happy to answer any question you have. And of course, afterward, you can ask questions in the chat or email me directly. Totally fine with that. Okay? All right. So we left off on enoxaparin, which is Lovenox. Maybe some of you have given it. We talked about how it's a shorter molecule of heparin. It's virtually the same thing as heparin. There are no dietary restrictions. So what is important to know is which medications have dietary restrictions and what are the dietary restrictions? Some of them do. Coumadin, warfarin, same drug. I'm going to use those two words and terms interchangeably because you're going to hear people using them interchangeably. So there's something called INR, and that's the internationalized, I always have to think about what exactly that abbreviation is. It is international normalized ratio. International normalized ratio. So that INR, because we just refer to it as INR, but that's what it's called. You're never going to hear anyone talk about that except for me today. Anyway, that INR is required for patients who take warfarin and Coumadin. It is not required for enoxaparin or any of the factor 10A inhibitors. It is given subcutaneously only. It is not available in PO. It's for the prevention of DVT after surgery for the most part. It can also be used with pregnant women. It's often given to pregnant women for DVT prophylaxis. So frequently it's used for DVT prophylaxis for patients who are at risk of a DVT. We all know that pregnancy puts a woman in a hypercoagulable state, so they are at risk of a DVT. There's a lower risk for bleeding and thrombocytopenia. Many physicians, providers like to use this. Bleeding is a serious adverse effect of a low molecular weight heparin. Okay, warfarin. I started to talk a lot about warfarin yesterday. So this is an oral medication only. It's used to treat DVT and PEs, pulmonary embolism. And these are usually for patients that are diagnosed with it. We initially put them on a medication that is not warfarin or Coumadin. Why don't we initially just put them on warfarin? Why? Anybody know why we don't just automatically go to warfarin if somebody has a DVT? They're in the hospital. We notice it. It takes too long to become therapeutic. Excellent. It can take 2, 3, 4, 5 days to become therapeutic. Hence, we start the patient on IV heparin. We start them on the IV heparin. We can get them therapeutic usually within 24 hours. Sometimes they're too high, they're too low. And that's when we are checking the PTT on that. Okay. So we're checking their bleeding time. PTT is related to heparin. PT-INR is related to Coumadin. The INR, the PT-INR is only related to patients who are on Coumadin or warfarin, same drug. And the PT, the prothrombin time, that's what they're looking for. We're really looking at that INR. The INR value for someone who needs to be anticoagulated should be between 2 and 3. Very important to know because when you're checking INRs and you're looking at labs on your patients, if they need to be anticoagulated and they're on Coumadin, their INR should be between 2 to 3, ideally 2.5. Now, if we were to check a patient's INR, probably like most of us who are not on Coumadin, I am not on Coumadin. If we were to check the INR, it would be, anybody know what a normal INR is for someone who does not need to be anticoagulated? It's around 1. Okay, it's about 0.8 to 1 point, somewhere in there. It's around 1, exactly. So you want to know, if you look and you're looking up their INR and you see that it is 1, they're in a normal state. Okay, that is where they should be, and that is great. If it's 2.3, 2.5, they're on Coumadin, and the ideal, every patient might be a little bit different. Some providers, for whatever is in the patient's history and going on with the patient, they may need to be on a little bit higher. They may need it to be closer to 3 or 3.5 or something, but somewhere between 2 and 3, and it can be a little bit more individualized depending on the patient. And that's only if they're on Coumadin. If they are on any of those factor 10A inhibitors, such as Eliquis and Xarelto, okay, apixaban, if they're on any of those, the INR is not relevant. We don't measure INR. We don't look at INR. And when those drugs first came out, the providers were like, what do you mean? How do we know? How do we know if the blood's too thin? How do we know? Because they're so used to Coumadin. And Coumadin was always, we looked at that INR, and the patients needed to go frequently to make sure that they were eating appropriately and it wasn't going too high or too low. And the providers would adjust the dose. So like I said yesterday, some patients can take 5 in one day. Some will take 5 every day. Some will take 5 and then maybe two another day on Monday, Wednesday, Friday. So the provider is the person that is going to prescribe the dose of warfarin based on the INR. And in the beginning, they need to go for that INR very frequently, like maybe every 2 days, that frequently. Initially, when it's initially prescribed, they have to go very frequently, because if they wait like a week, that INR can be either extremely high, extremely low. You can't gamble with it. You have to be exact. Patients need to be compliant. Very important. If this is a patient who cannot get to the lab, or they can't have someone come to the house and get their blood drawn, Coumadin is not the drug for them. So I mentioned that when a patient has a brand new DVT, they initially go on the heparin. So it's given with heparin. That's called the bridging process. There are many dietary restrictions with warfarin, such as if you eat lots of dark green leafy vegetables, it can affect the INR. And we had a little discussion, I think, after class. Some of you may have stayed on for a couple minutes, and you may have heard that the INR is definitely affected by some of these foods. And so what we tell our patients is we don't say don't eat. We don't want you eating, spinach and lettuce and salads. Because I've been out with patients or people who are, they're patients, but they're people to me. And they say, I can't eat, broccoli, and I can't eat this because I'm on Coumadin. And, it's really not that they can't eat it. They just have to eat a consistent diet. As I mentioned yesterday, you can't eat like a whole bunch of broccoli today, and then tomorrow and the next day you don't eat any, or then like for 2 or 3 days you eat a whole lot and then you don't eat any, because that can change your INR value. That can cause your INR to go down, okay, if you eat a lot of dark green leafy vegetables, because there's natural vitamin K, and vitamin K is the antagonist. That's the medication we give patients if their INR is too high, okay? We'll give them some vitamin K. So there are dietary restrictions. They need frequent blood work to check that INR, and it's contraindicated in pregnant women. What medication is indicated? What anticoagulant is indicated for pregnant women? Anybody remember? Okay, heparin or Lovenox, excellent. Those are indicated, excellent, very good. Okay, so now we have our factor 10A inhibitors. These are anticoagulants. So there are different levels of coagulability for our patients. So there are different medications. So some medications are much stronger. So our thrombolytics, they are the strongest of them. Okay, so a thrombolytic, what is a thrombolytic? My group should know because we talked about this Monday in clinical. Thrombus means what? It breaks up clots. Exactly. Thrombus is clots and lysis is breakup. Exactly. Excellent. So, except I don't see anybody in my group answering these questions. I'm just teasing you. Anyway, so yes, thrombolytics. Thrombolytics are the big guns. Okay, they're heavy duty. They're very, very potent. We want to be extremely careful with who we give thrombolytics to. Okay, under thrombolytics are anticoagulants. They're also pretty potent because you can get a bleed. You can get a bleed anywhere. You could, like I mentioned yesterday, you can bleed in your, your urine, in your stool. You can have a nosebleed. Nosebleed, not so serious. Bleed in the brain, very serious. So you really have to look at. Now, some providers will not put certain patients on any anticoagulants. Anybody have an idea why? Why would a patient not be placed on an anticoagulant if they've had a DVT? We treat the DVT, but long term. Anybody have any idea what patient might not be a candidate? If they have a bleeding disorder, okay. But one in particular are patients that fall a lot. So if they're a fall risk, because providers are really afraid, they don't want the patient to fall or who fall frequently, because serious things can happen if you fall frequently. As we know, you can get a hip fracture, you can break bones, all that kind of stuff, but you can also get a bleed if you are on an anticoagulant. So they're very careful. Today, it's kind of so the levels 2 to 3 is a therapeutic level. Yes, that is exactly correct. What would be the normal value for PT-INR for a patient who's not anticoagulated? It's around 1. So if they need to be anticoagulated, it's 2 to 3. Anyway, patients who are fall risk, they are at high risk for bleeding. So some providers do not feel comfortable putting patients who are in fall risk on these anticoagulants. It's a personal decision between the patient and the provider because this is a strong medication. So anybody who's in an occupation where they can bleed, I don't know, their job might be dangerous or something, you want to really have a conversation with your provider and let them know so that you can make the decision together. So factor 10A inhibitors, you do not have to know how they work. I want you to know that they're anticoagulants. It's nice to know that they inhibit factor 10A in the clotting cascade. Okay. And therapeutic value is achieved very, very quickly, like in hours, in like maybe 6 hours. And some providers will place a patient on Xarelto or Eliquis immediately when they have a DVT and not even admit them to the hospital. So that can happen too. Patients who are admitted to the hospital sometimes are the ones that come in because they have symptoms and they don't know the problem. Then the DVT is discovered. But if a person calls a provider and says, I fell and I have swelling in my leg, they may, as an outpatient, send them for what's the test they're going to get? What should they go for? How do we tell? What's the number one test that we usually use? The D dimer. We can do the D dimer, and we can also do an ultrasound. We can do an ultrasound. Remember the ultrasound of the leg as well. So, can these be given without heparin? Absolutely. They can be given with or without heparin. We do not have to start them on heparin. Patients can go on Coumadin let's put it this way, if they have an acute problem, right now, DVT in their body, PE in their body, we need to fix that. We need to put them on an anticoagulant immediately, such as Xarelto or Eliquis or heparin. Any of those will act rapidly. Coumadin takes time. So with Coumadin, we'll start them on heparin and then put them on Coumadin. We can start them on heparin and discharge them on Eliquis, Xarelto. That happens more commonly than patients who are discharged on Coumadin, because Coumadin is an old time drug. Now it is. When I started practicing, all we had was Coumadin. That was the anticoagulant. Everybody had to go get their INRs checked. Then about, I'm not exactly sure, maybe close to 10 years ago, 8 or 9 years ago, drug companies came out with this, factor 10A inhibitor. And now that is the drug of choice. So very few patients are on Coumadin. The ones who are on Coumadin are the ones who've been on Coumadin for 20, 30, 40 years. You may know some. You may know maybe some of your grandparents, your family members have been on Coumadin. And you know what? Coumadin works for them. It's cheap. I remember I mentioned the price, and you can say, oh, well, who cares about that? No. Families who do not have money who can barely afford groceries, okay, it's going to be a real stretch and a hardship for them to be placed on this medication. So Coumadin is also available, and it's much less expensive. So these are the drugs of choice. So it can be given with heparin, or it doesn't have to be. It can be given an outpatient. Xarelto or Eliquis, my brother-in-law called me last week and said, oh my God, he said, I'm suddenly diagnosed with AFib. He said, and my cardiologist wants me to go on one of these factor 10A inhibitors, Xarelto or Eliquis. I don't know. What do you think? I said, absolutely. You absolutely need to go on it. So he was not in a situation where he had a clot. If he had a clot, then he would need to go. He would need to be on something immediately. And sometimes they put them on, like I said, my other brother-in-law, actually a couple of years ago, he had a DVT, called the doctor, went for an ultrasound, and the provider said, yes, it's a DVT. And she immediately put him on, I don't know, one of them, Xarelto, I think. So my brother-in-law with the AFib, I said, you absolutely need to go on one of these. And he said, okay, called the cardiologist and said that, he said, I can't believe it. I said, yeah, well, life happens, right? Anyway, so that's how it works. All right. So there is, okay. So the downside, so, you want to say, well, this is great. There's no INR monitoring. You can eat anything you want. There's no dietary restrictions. So you're probably thinking, wow, this is great. Why doesn't everybody go on it? If you can afford it, why don't you go on it? Right. Okay. So the downside to this drug is there's no real antagonist. So I say no real antagonist. They're coming up with antagonists for it. But the problem is, and why a lot of providers do not want, some providers don't want their patients on it. They're extremely afraid in the beginning, because what do we do if they come in with a bleed? How do we reverse it? And they're bleeding. What do we do? So with Coumadin, there's an antagonist. What's the antagonist to Coumadin? You want to know it. Vitamin K. Excellent. There's also an antagonist to heparin. What is the antagonist to heparin? Protamine sulfate. Excellent. Protamine sulfate. Yes. So you want to know the antagonists. Now, guess what? You give vitamin K, you give protamine sulfate. They are not antagonists for Xarelto or Eliquis. So a lot of providers initially, 5, 6, 7, when they first came out 5, 6, 7 years ago, were like, I don't want my patient on it. There's no antagonist. There's nothing. If they come in, they've been in an accident or something, and they're bleeding, we can't reverse it. We need to do surgery on this patient immediately, even if they're not bleeding. They're in an accident, a car accident or something, and they need, they come in as a trauma and they need surgery. What are we going to do? They're on this medication. So hence, since there is a medication, it's called Kcentra. It's an IV medication. It's given in the emergency room. The emergency room nurses do know how to mix it in case there is a serious problem. So there is an antagonist. They're coming out with it. There's some restrictions, but it's a new drug. And, providers, understandably are a little cautious. So when Xarelto and Eliquis first came out, providers were incredibly cautious about it. They didn't want to use it. And now more and more, it's becoming more popular. Patients are doing very well on it. So more and more providers are using it. I'm spending a ton of time. Farm Book says Adexa is an antidote. Okay, that might be a newer one. So they're coming out with some antidotes is my point. A while ago, they did not. What about blood clotting product through IV? I don't understand what you mean, a blood clotting product. And I was mentioning, if you can, try to just hold your questions, and then I'm happy to answer them at the end. I'm spending a ton of time on Xarelto and Eliquis and heparin and Coumadin. They're incredibly important drugs. Many of your patients are on them. How many of you have seen and had patients who are on these medications? You can just say yes or whatever.
Yes.
Anybody have? You can raise your hand lower. Yeah,
Yes.
yeah. A lot. Yes. A lot of your patients are on these medications. Yes. Okay. Then there's antiplatelet medications. Antiplatelets are just that. They are antiplatelets. They are NSAIDs. They are not as strong. They are nowhere near as strong as an anticoagulant. So you're going to see some patients on aspirin, Plavix, clopidogrel, or Plavix. Brilinta. Brilinta is mainly given for cardiac purposes. Pletal and Trental are given for intermittent claudication. I'm going to talk about that very soon. Okay. These medications are antiplatelet, not as strong. So there's a difference. Remember, I was mentioning the hierarchy. The thrombolytics are the highest. They're the strongest. They're the big guns. Then after that comes your anticoagulants. Then you have your antiplatelets. They're all considered hold on. Well, antiplatelets, they're all in the category thrombolytics, but they don't break up clots. Okay. Thrombolytics. Let's talk about thrombolytics. So these are the ones that break up the clot. I already talked about them. IV medications used to dissolve fibrin clot. And this is what we give when patients come in and they have a stroke. We give this tissue plasminogen activator. We give the TPA. Well, what happened to my little right here? This is what we give. And some of you, I know, Brittany, you had a patient on Monday with me, and the patient was going down to get some TPA into the vessel to try to open up that artery. Okay. So it's used to treat embolic stroke, must be given within 3 hours of onset of stroke. You do not have to know this. Know what a thrombolytic is, that it breaks up a clot. Surgery can be done. And they can venous thrombectomy when necessary to prevent a PE or gangrene. They do not do this. They don't usually go in. It depends. I mean, I can't say it is an option, but it's not given. It's not done that frequently. We just don't go in and try to remove that clot. If a patient is not a candidate for anticoagulant therapy and they're seriously prone to have more clots, we need to do some. What else can we do? So another intervention that they do is they put in what we call an IVC filter, inferior vena cava filter. Sometimes they're called greenfield filters. You may have heard of them as a greenfield filter. It's a filter that's placed under fluoroscopy, and they have local anesthesia, and they go down and they get this filter placed so that when blood comes through, it does not get to the heart and the lungs if there is a clot in the blood. Okay, so it's a little filter that can be placed. Some patients may have it. Okay, DVTs in infants are very rare. Adolescents are 8 times greater than infants, but still quite rare. Pregnant women are 4 to 5 times greater risk than a non-pregnant woman of getting a clot. The risk is greatest in the first 20 weeks of gestation. We all know that it's 40 weeks. So halfway through in the beginning, they're at greatest risk. Greater during postpartum than pregnancy. And then postpartum in the very beginning, you are also at risk. Heparin is preferred over Coumadin. Mentioned that. We do not give Coumadin to pregnant women, we give Lovenox and heparin. Excellent. Older adults are also at risk. It increases your higher risk chance of getting it as you get older because of venous stasis, immobility, and cancer. That's why you get more of these things. You're not mobile, right? Most of our elder, not most, some of our elderly are, homebound, don't get out much, have problems with their knees, problems with their hips, a lot of pain. So they have increased risk because they're immobile. Younger women are at an increased risk with estrogen. So, and also patients who are taking hormone replacement in menopause are also at an increased risk. Anticoagulants, Xarelto, Eliquis, Savesa. I have not seen anybody on Savesa. It came out a little bit ago. It's the newest one, but I don't see it being ordered. These are oral medications. They're used to treat DVT and PE, inhibits the factor 10A in the clotting cascade. Therapeutic value is achieved very quickly. Given together with heparin. Okay, did I go backwards? Okay, no. Okay, here we are. Case study. A 72-year-old male presented at the hospital complaining of severe pain in his left leg. Following a long drive from Connecticut to Florida with minimal stopping. He wanted to get home. The patient has a history of diabetes, degenerative joint disease, and he was a chronic smoker. The patient is placed on an anticoagulant. So this is where I wanted you. We don't know which anticoagulant they were placed on, but what can we do for this patient? So let's look at some potential things. So if the patient's placed on Coumadin, what kind of a teaching plan? I asked you to come up with a teaching plan. And what are we going to do for this particular patient? How about warfarin? What are we going to tell the patient? What do they need to do? Avoid green. Do we want to tell them to avoid it?
You can get up frequently. It will take a while to take effect.
It's going to take a while to take effect. Okay. It can be given with heparin, right? But they're going home on it. They're now therapeutic. They're on it. What do we want to tell them about? You'll need to have a lot of blood work. Excellent. They're going to require frequent blood work with Coumadin. Excellent. Okay. And what about the diet though? Consistent diet. Thank you, Heidi. Excellent. Consistent diet is what we need to be telling them. They don't have to necessarily avoid the greens. They need to eat it consistently.
To watch their feet for any injuries or anything, especially since he has diabetes, so he might not feel the bleeding.
We want to have them take a mirror and check their feet. Absolutely, because they can get bleeding or bruising can happen before the bleeding. All right, and they may not even feel the soreness from a bruise that they may have hit their foot. Excellent. Excellent. Yeah, take it the same time every day. For the most part, it's 6 o'clock at night. And there are bleeding precautions. Okay, great. Avoid excessive alcohol. Very true. The case with most drugs. Excellent. Okay, a patient now, if he's placed on Xarelto, what do you think we want to tell him about the Xarelto? Anything they need to do? Just monitor for that bruising. Yeah, there's no labs. They don't have to go. Excellent. Okay, now this is all really, really important information. You're going to have to know this for the exam, and not just for the exam, but for when you're taking care of patients. Avoid high-risk activities that could lead to falls. Yes, biking, skiing, excellent. And that's why, excellent, Stephanie, because that's for any of these anticoagulants. And we want to just make sure that, they don't fall. Remember, I mentioned that some patients who will not be placed on an anticoagulant are patients who are at a high risk for falls and who partake in an activity where they can get hit or bruised or fall down or playing football or something. That can be a very, a serious injury if they do sustain an injury during the sport. Okay. Tell the MD for both before procedure, not sure. No boxing. Ha ha. Yeah, no boxing. Yeah, I don't think that would be too smart. Report signs and symptoms of bleeding immediately. Absolutely. So these are your bleeding precautions that you need to be instructing your patients on. Okay, you want to be telling them to watch for any signs and symptoms of bleeding. A few years back, I was teaching, in I forgot what hospital it was. I think I can't remember. It was before I started working for Naugatuck Valley. I think I was with my Quinnipiac students. But anyway, we were in a hospital, in Milford Hospital, I think it was. And I never even knew there was a Milford Hospital. And a patient came in and was admitted. Their entire hand and arm was so swollen. And I mean swollen. And it was an enormous hematoma. And I've never seen a hand like that. And I said, oh my goodness. I said, what happened? And they said, this was from, I believe it was Coumadin. And I said, really? And they said that he cut himself. And I said, did you apply pressure? Oh yeah, we applied pressure and pressure and pressure. And they could not get the bleeding to stop. So, when you're a nurse and you're starting IVs, when you learn how to actually inject into the hand, if you have a patient on Coumadin, know that it can take them a little bit longer to bleed. Or, you see some of your guys are watching the PCAs drawing blood in the anticube area or anywhere in a vein. And sometimes they just slap that gauze on. Okay, yes, but you want to check. Whenever you remove an IV, you may not know if your patient's on Coumadin or not, might not be your patient, some of you guys. Apply pressure until it stops. Excellent. Because you don't want to just put that gauze on, tape it. Guess what? You come back in 15 minutes and there's blood everywhere. So some patients bleed a lot more and some don't. You don't know how your body's going to react. So absolutely monitor all signs and symptoms of bleeding and report it. Okay. All right. Excellent. How about group 3, which we didn't divide up into groups? I gave everybody this assignment. Non-pharmacological therapy. What are we going to do? What can we do for a patient who has a DVT?
Green leafy vegetables.
Okay. So compression socks. Good point. Now let's talk about compression socks. Do we want to put compression socks on when the patient is in an acute state of a clot? When they have that clot happening? No. When it's swollen and red and they have that clot actively in their body, we do not want to put the compression hose on. Afterward or for prophylaxis? Absolutely. To prevent a DVT, compression stockings are awesome.
How about a warm, moist cloth? I thought I read.
We can put warm on. Yes, we can put a warm, moist compression over the affected vein. Excellent, because we want to try to reduce the inflammation. What else can we do to reduce the inflammation and relieve the symptoms? Elevate. Excellent. We want to elevate the leg. Excellent. So these are all the non-pharmacological. How about crossing the legs? Should we tell them to cross their legs? No. No crossing the legs. Okay. We want to progress them. We want to get them to ambulate once the DVT that we've discovered is when it's okay to, when it's kind of settled and they're on an anticoagulant and they are not at risk of it dislodging or moving. Okay. Because remember, the anticoagulant is not going to take the clot away. It's going to prevent it from doing what? Getting larger. Okay. It's going to prevent it from getting larger. Right. So we want to, once the patient is on an anticoagulant, then it's safe for them, for the most part, to ambulate. Wait for the doctor's orders, because we do not want it to move and turn into an embolism. An embolism is where it's going to move, and it can move to the heart and the lungs and the brain. So we want to use warm, not cold initially. We want to use warm, moist compressions, compresses, something. But not tight compresses. I'm just saying like a little bit of warm, moist cloth. Tell them to avoid prolonged sitting or standing. That's to prevent compression hose to prevent. There's a box on page, where is it? In your book. Oh, goodness. Oh, here it is right here. It's on page 1217 at the bottom. It talks about compression hose. It says elastic anti-embolism stockings or pneumatic compression devices. Okay, those are our Flowtron boots that we put on the legs. You know what I'm talking about, right? The machine, we wrap the leg in the pneumatic compression device. So that too, the Flowtron boots or the stockings are contraindicated in patients with known DVT, but they're frequently ordered by physicians for use in the prevention. So those are used to prevent a DVT, but once there is a DVT, we do not put the compression hose on or those boots on until after, usually like till after if they're in the hospital, pretty much they go home. Then we can tell them it's great to be wearing those compression hose. I can't say enough things. It's awesome to be wearing those compression stockings. Tell your patients to wear them on the plane. Okay. Some of you may have known, I recently went to Florida for spring break. I wore compression hose on the plane, not a long plane ride, but when I went to Japan, I wore compression hose. So I wear them in clinical. They're just so good to help your veins. It helps move that blood back up to the heart. Okay. I was sitting with a physician. He was a vascular surgeon. He gave a talk, and I'll bet it was, I don't even remember what it was on, but I'll bet it was on one of these anticoagulants. And he was advocating for compression hose. And he said to the group, and here he is, a vascular surgeon, and he's dressed in a suit. He said, I have them on right now as I'm talking to you. He said, I can't say enough about them. And I totally agree. So the tightness on the legs, and they make your legs feel comfortable, and tight fitting clothes only after you're on an anticoagulant if you have a DVT. So they're used for prophylaxis. Okay. Am I clear on that? I don't want anybody saying that, oh, I said that, to use compression hose. Yes. Use compression stockings, but not until the DVT is somewhat cleared up. Okay. Elevate the legs. We talked about that, because what's elevating the legs going to do? What's it going to do? It's going to promote venous return. Excellent. And it's going to discourage the venous pooling. Okay. Because it promotes venous return. It's helping with that flow, which is going to lead into our next topic. Promotes that venous return, which is so good. And if it doesn't, the blood is pooling. So if the blood is pooling and it's not moving, we're in a state of venous what? Stasis. Okay. Not good. Okay. We don't want that blood pooling, and then the blood just can't get back up. So always important to try to do the best we can to promote venous return. Okay. Let's go on to, okay. The nurse teaches the family of an older client who is at risk for developing DVT about prevention of the condition. What information will the nurse include in the teaching? Place pillows under the knees so that the hips are sharply flexed. Apply compression stockings only if swelling develops. Position client to best promote venous return. Keep feet squarely on the floor when sitting in a chair. What do you think? 3. Yes. 3 is the answer. If you can only pick one, Megan. Okay. All right. So, yeah, if swelling develops, we do not want to put compression stockings on, because there could be a clot in there. All right. So, good. Oh, I'm sorry. 2 choices. Yeah, I like 3 better. 4 is good. Yeah, sorry. You guys are right. Wow. Okay. Okay. Question 2. Well, these are the choices. I mean, it's not 2 choices. It was question 2. The choices for question 2. It is okay to have your feet squarely on the floor, but yeah, I guess you could include both of them. You could include both. It wasn't necessarily a multiple choice. Okay. Are we done? I think we're done. There was something else. So it's all about prevention. Elevate the foot, okay, on those orthopedic patients. What else can we tell our patients to do that would really help in preventing DVT? We talked about the compression stockings. What else? Ambulate, 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 and exercise. Get them and try to encourage them and you guys. I try to encourage everybody to get on some kind of a regime for a normal exercise regime if they're able to. Take a walk 15, 20 minutes every single day. It's going to help with so many things, including, prevention of diabetes if they're pre-diabetic. So yeah, do those ankle flexions in bed, leg extensions, all that in bed. Get them moving. So the bottom line for all these things is really some type of an exercise program. Yeah, avoid crossing legs. Excellent. Okay, great. Take just 2 minutes. I'm going to give you a 2-minute break while I bring up the next PowerPoint because we got a lot of information on that one. Great job, everyone. 2-minute break. Come back at 10:18.